Hello and welcome. If the D440 OA exam has been on your mind and you're wondering how to approach it, then you're in the right place. Our website has D440 OA questions and answers, and it won't cost you a thing. OA exams are tough, so everything from guides to practice questions is free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from clinical nutrition, maternal nutrition, dietary therapy, parenteral support, micronutrient essentials. So, let's get started.
1. A nurse is evaluating a newly admitted adult client and wants to build a complete nutritional status picture rather than rely on one measure alone. Which combination of assessment methods would give the most accurate and well-rounded clinical snapshot? A. Daily weight trend alone. B. Self-reported appetite survey. C. Physical, anthropometric, and biochemical markers. D. Height and age only. Can you guess the answer? Only. Correct answer, C. Physical, anthropometric, and biochemical markers. Explanation. Option C is correct, because accurate nutritional assessment pulls from physical appearance, anthropometric data like weight and body composition, and biochemical markers such as albumin and iron status to build a full clinical picture of the client. Option A is incorrect because a daily weight trend alone misses critical information about lean mass, hydration shifts, micronutrient status, and visible signs of deficiency that guide clinical decision-making at the bedside. Option B is incorrect because a self-reported appetite survey provides subjective data only and cannot reveal hidden deficiencies, fluid shifts, or lab changes that drive nutritional diagnoses and care plans. Option D is incorrect because height and age alone cannot assess current nutritional state, since they do not capture weight changes, muscle wasting, laboratory values, or physical signs of nutrient deficiency.
Let's unpack what goes into a real nutritional assessment at the bedside. When a nurse wants to know where a client actually stands nutritionally, one number will never tell the whole story. A daily weight alone hides muscle wasting. An appetite survey misses low iron. Height and age say nothing about what is happening inside the body right now. The answer is to pull together three different lenses at once: physical appearance, anthropometric data like weight and body composition, and biochemical markers such as albumin, prealbumin, and iron studies. Each lens catches something the others miss. Physical exam shows hair, skin, and muscle changes. Anthropometrics give you measurable trends. Lab values reveal hidden protein and micronutrient problems. Put together, they form a complete clinical snapshot that guides a real care plan. Here's a Would You Do D440 OA exam tip for you. When a question asks for the best overall assessment, pick the option with the most data sources combined. Quick recall hook: 3 letters, PAB, physical, data, anthropometric, biochemical.
2. A primary care provider reviews routine labs and body measurements during a client's annual physical exam today. The client's body composition places them just above the healthy range, but clearly below the obese threshold. Which classification best describes this client's current weight status? A. Overweight. B. Extremely obese. C. Normal weight. D. Underweight. Do you know the answer? Correct answer, A. Overweight. Explanation. Option A is correct because adults whose body mass index falls above the healthy threshold but below the obese cutoff are classified as overweight. This range signals increased metabolic risk without yet meeting criteria for clinical obesity. Option B is incorrect because extremely obese applies to adults with a body mass index well beyond the standard obese threshold, which is a much higher reading than this client's measurements reflect. Option C is incorrect because normal weight describes adults whose body mass index sits within the healthy range, and this client has already moved above that upper healthy cutoff based on the scenario. Option D is incorrect because underweight describes adults whose body mass index falls below the healthy lower cutoff, which indicates possible malnutrition rather than the excess body weight described here.
Here's how BMI classification works in plain terms. Body mass index sorts adults into 4 basic buckets: underweight, normal weight, overweight, and obese. The scenario tells you the client sits just above the healthy range, but clearly below the obese threshold. That narrow band has a specific name, and it is overweight. Underweight means BMI below 18.5. Normal weight covers 18.5 up to 24.9. Overweight runs from 25 up to 29.9. Obesish starts at 30. Extremely obese, sometimes called Class 3 obesity, kicks in at 40 and above, which sits far higher than the client described. Memorize these 4 boundaries once and BMI questions become simple pattern matching. Here is a wide D440 OA exam tip for you. When the question says just above healthy but below obese, that is always overweight. Quick recall hook: 25 to 30 equals the overweight window. 25 to 30, easy to remember.
3. A dietitian is determining whether a client's ideal weight range should account for bone structure rather than using standard tables alone. Which measurement approach provides the most useful anatomical reference for this adjustment in everyday clinical practice today? A. Waist circumference measurement. B. Hip to waist ratio. C. Skin fold thickness reading. D. Height divided by wrist circumference. Do you know the answer? Correct answer, D. Height divided by wrist circumference. Explanation: Option D is correct because frame size is determined by dividing the person's height by their wrist circumference. This ratio reflects skeletal structure and helps individualize ideal weight targets beyond generic height-based reference tables. Option A is incorrect because waist circumference measures central fat distribution and cardiovascular risk. It does not indicate skeletal frame size or help tailor ideal weight targets to bone structure in any meaningful way. Option B is incorrect because the hip to waist ratio assesses fat distribution patterns linked to metabolic risk. It offers no information about the client's underlying skeletal frame dimensions or bone size. Option C is incorrect because skin fold thickness estimates body fat percentage at specific anatomical sites. This measurement cannot indicate bone structure or skeletal frame size for ideal weight adjustments in clinical practice.
Let's dig into frame size and why it matters for ideal weight calculations. Standard height-weight tables treat every adult of the same height as if they share the same skeleton. That assumption breaks down fast in real practice. A person with a large skeletal frame carries more bone and more supporting tissue than a person with a small frame at the same height. To adjust for this, clinicians use a simple ratio: height divided by wrist circumference. Wrist circumference reflects bone dimensions without much fat or muscle interfering. A higher ratio means a smaller frame. A lower ratio means a larger frame. Here's a D440 OA exam tip for you. When the question mentions skeletal frame or bone structure, look for the option with wrist. Quick recall hook: wrist equals bone. All the other options measure fat.
4. A community health nurse is designing a nutrition screening program and wants to prioritize the populations most vulnerable to malnutrition. Which group of clients should the screening program target first based on well-established risk factors in the population? A. Young professional adults. B. Pregnant women, infants and elderly. C. Competitive endurance athletes. D. Middle-aged healthy adults. What do you think is the answer? Correct answer, B. Pregnant women, infants, and elderly. Explanation: Option B is correct because pregnant women, infants, children, and elderly adults carry the highest malnutrition risk due to increased nutrient demands rapid growth, or reduced intake and absorption tied to aging and chronic conditions. Option A is incorrect because young professional adults generally meet nutrient needs through regular intake and have no elevated physiological demand that places them at baseline high malnutrition risk compared with other groups. Option C is incorrect because competitive endurance athletes carry some nutritional risks, but their access to food and sports nutrition support keeps them well outside the highest priority risk groups for malnutrition. Option D is incorrect because middle-aged healthy adults without chronic disease or food insecurity fall into the lowest risk category for malnutrition compared with growth stages, advanced age, or pregnancy.
Think about who shows up at a nutrition screening clinic with the highest risk. Screening programs exist because certain populations face biological demands or barriers that push them toward malnutrition faster than the average adult. Pregnant women carry extra nutrient demand for fetal growth and maternal tissue expansion. Infants grow fast and cannot feed themselves, so any feeding disruption shows up quickly in their labs and weight curves. Elderly adults face reduced appetite, lower absorption, chronic disease, dental issues, and sometimes social isolation that limits food access. Young professional adults, competitive athletes, and middle-aged healthy adults all eat enough and have intact absorption. They are not the priority group. The screening program lands on pregnant women, infants, and elderly because those three stages share the highest baseline malnutrition risk in the population. Here's a D440 OA exam tip for you. When the question asks about highest malnutrition risk, pick the option with life stage extremes. Quick recall hook, PIE, pregnant, infant, elderly.
5. A nurse reviewing admission labs wants to identify which values best reflect the client's current protein status and overall nutritional reserves. Which laboratory markers are most directly used to evaluate this specific clinical question during an inpatient workup? A. Hemoglobin and hematocrit. B. Sodium and potassium. C. Albumin and prealbumin. D. White blood cell count. What do you think is the answer? Correct answer, C. Albumin and prealbumin. Explanation: option C is correct because albumin and prealbumin are the standard biochemical markers for assessing protein status and nutritional reserves. Prealbumin tracks recent intake, while albumin reflects longer-term protein stores in the body. Option A is incorrect because hemoglobin and hematocrit reflect oxygen carrying capacity and iron status. They do not directly indicate protein reserves or overall nutritional adequacy in the way albumin does. Option B is incorrect because sodium and potassium reflect fluid balance and electrolyte status. These values shift with hydration and medications rather than tracking nutritional protein reserves or recent dietary intake. Option D is incorrect because a white blood cell count reflects immune response and infection status. While severe malnutrition can lower immunity, this marker is not a direct nutritional indicator in clinical practice.
Here is how lab values talk about protein status. When a client comes in and the clinician needs to check nutritional reserves, two specific labs do the heavy lifting: albumin and prealbumin. Albumin is a protein made by the liver that stays in circulation for about 21 days. It reflects longer-term protein stores in the body. Prealbumin has a much shorter half-life, about 2 days, so it catches recent changes in protein intake quickly. Together, they show both the long view and the short view of protein nutrition. Hemoglobin and hematocrit track oxygen carrying capacity and iron status, not protein. Sodium and potassium track fluid and electrolyte balance. White blood cell count tracks infection. None of those three answer the protein question directly. Here's a D440 OA exam tip for you. When you see the words protein status or nutritional reserves in the stem, jump straight to albumin and prealbumin. Quick recall hook: albumin and prealbumin both start with A and P. Assess protein.
6. A preconception counsellor is meeting with a woman who is planning to conceive within the next 6 months. Which vitamin should be prioritized in her daily diet well before pregnancy begins to prevent the most serious early developmental defect? A. Folic acid. B. Vitamin C. C. Vitamin E. D. Biotin. Can you guess the answer? Correct answer, A. Folic acid. Explanation: option A is correct because folic acid supports DNA synthesis, cell division, and proper neural tube closure during the earliest weeks of gestation. Adequate stores built before conception are the single strongest protection against neural tube defects. Option B is incorrect because vitamin C supports immune function, collagen synthesis, and iron absorption. It is not the primary preconception nutrient tied to preventing neural tube defects in early fetal development. Option C is incorrect because vitamin E acts as an antioxidant and supports cell membrane integrity. It has no specific role in preventing the serious early developmental defect that folate directly addresses. Option D is incorrect because biotin supports metabolism of fats, proteins, and carbohydrates. Deficiency during preconception is rare, and biotin is not linked to neural tube closure during early gestation.
Let's talk about why folic acid rules the preconception nutrition conversation. The neural tube forms between day 21 and day 28 of gestation, which is often before a woman even knows she is pregnant. That tube closes into the brain and spinal cord. Without enough folate on board when closure happens, the tube can fail to close properly, causing serious birth defects like spina bifida and anencephaly. This is why clinicians push folic acid supplementation well before pregnancy begins, not after the test turns positive. Vitamin C supports immunity and collagen. Vitamin E protects cell membranes toned. Biotin handles fat and protein metabolism. None of them touch neural tube closure. Only folic acid carries that specific preconception role, and the timing is the whole point. Here's a YGU D440 OA exam tip for you. When the question mentions preconception or early pregnancy birth defects, the answer is always folic acid. Quick recall hook: folate fetal spine. Both start with F.
7. A nurse is counselling a healthy pregnant client during her very first prenatal visit about calorie adjustments throughout pregnancy. In which specific stage does the client not need to add any additional calories to her usual daily intake pattern? A. Second trimester. B. Third trimester. C. First 6 months of lactation. D. First trimester. Can you guess the answer? Correct answer, D. First trimester. Explanation: option D is correct because the first trimester requires no added calories because fetal growth demands remain minimal during these early weeks. Calorie needs rise during the second and third trimesters as fetal tissue expansion speeds up. Option A is incorrect because the second trimester requires added caloric intake to support increased maternal blood volume, placental growth, and fetal tissue development during this active expansion phase of pregnancy. Option B is incorrect because the third trimester demands the largest calorie addition due to rapid fetal growth, amniotic fluid production, and continued placental and maternal tissue development during the final months. Option C is incorrect because the first 6 months of lactation require substantial added calories to support milk production, with part of that energy pulled from maternal stores and part from daily diet.
Here is how pregnancy calorie math actually works. The first trimester sounds like it should demand extra calories because a baby is growing, but fetal growth in those first weeks stays minimal. The embryo weighs almost nothing. The placenta is still forming. Maternal tissue changes are just beginning. So the calorie recommendation for the first trimester matches pre-pregnancy intake. No added calories. Things change in the second trimester where roughly 300 extra daily calories cover placental growth, maternal blood volume expansion, and fetal tissue buildup. The third trimester demands even more, often around 450 added daily calories for rapid fetal weight gain. Lactation adds about 500 calories a day to support milk production. So the only stage without added calories is the first trimester. Here's a What You Do D440 OA exam tip for you. When the question asks which stage needs no extra calories, the answer is always first trimester. Quick recall hook, first trimester 0 tot. Both start with ground floor amounts.
8. A registered dietitian is building a meal plan for a pregnant client who wants plant-based fat sources throughout her pregnancy. Which foods should the dietitian recommend to help her meet the increased daily need for alpha-linolenic acid? A. Butter and coconut oil. B. Flax, chia, walnut and soybean oil. C. Lard and palm oil. D. Beef tallow and cream. Do you know the answer? Correct answer, B. Flax, chia, walnut and soybean oil. Explanation: option B is correct, because flax, chia, walnut and soybean oil are the richest plant sources of alpha-linolenic acid. Pregnancy raises the daily requirement for this essential fatty acid, modestly but steadily across trimesters. And these foods effectively help meet that increased need. Option A is incorrect because butter and coconut oil carry high saturated fat with very little alpha-linolenic acid content. These fats do not meet the increased essential fatty acid need during pregnancy. Option C is incorrect because lard and palm oil carry high saturated fat loads and negligible alpha-linolenic acid. These options do not support the essential fatty acid increase that pregnancy requires. Option D is incorrect because beef tallow and cream deliver saturated fats rather than essential fatty acids. They do not contribute meaningfully to the pregnant client's alpha-linolenic acid intake during pregnancy.
Let's look at plant-based omega-3 fats during pregnancy. Alpha-linolenic acid, or ALA, is an essential fatty acid the body cannot make on its own. Pregnancy raises daily need for this fat because it supports fetal brain and eye development throughout gestation. Plant sources load up in specific places: flax seeds, chia seeds, walnuts, and soybean and canola oils. These foods carry concentrated ALA per serving and fit easily into a meal plan. Butter, coconut oil, lard, palm oil, beef tallow, and cream all carry mostly saturated fat with almost no ALA.D. They deliver calories but do not meet the essential fatty acid target. When the question asks for plant-based ALA sources, the short answer lives in seeds, nuts, and plant oils with that signature tan or golden color. Here's a Wagyu D440 OA exam tip for you. When you see the words essential fatty acid or ALA, scan for flax, chia, walnut, and soybean. Animal fats never win this question. Quick recall hook: seeds and walnuts start omega. Sin, WSO.
9. A nurse educator is explaining to a prenatal class why folate intake matters most in the earliest weeks of pregnancy, often before many women even know they are pregnant at all. Which developmental event drives this narrow critical window? A. Neural tube closure in the 3rd and 4th week. B. Placental attachment to the uterine wall. C. Fetal lung surfactant production. D. Skeletal mineralization and growth. Can you guess the answer? Correct answer, A. Neural tube closure in the 3rd and 4th week. Explanation: option A is correct because the neural tube forms and closes roughly between day 21 and day 28 of gestation. This process requires adequate folate stores and later becomes the spinal column and nerves, which is why folate intake is critical in the earliest weeks of pregnancy. Option B is incorrect because placental attachment occurs during implantation and early pregnancy, but does not depend on folate status in the same narrow window that neural tube closure absolutely requires. Option C is incorrect because fetal lung surfactant production happens much later in gestation, primarily during the 3rd trimester. It is unrelated to the early folate critical window before week 6. Option D is incorrect because skeletal mineralization progresses across the entire pregnancy and accelerates during later trimesters. It does not define the earliest folate critical window tied to neural tube closure.
Here is the timing window that makes folate so critical early in pregnancy. The neural tube is the embryonic structure that becomes the brain and spinal cord. It forms and then closes between day 21 and day 28 of gestation. That entire process wraps up before many women even miss a period or take a pregnancy test. If folate stores run low during those specific days, the tube may fail to close. The result is a neural tube defect like spina bifida or an encephaly, both of which carry lifelong disability or early death. Placental attachment happens earlier during implantation, but does not depend on folate in the same tight window. Lung surfactant production runs in the 3rd trimester. Skeletal mineralization stretches across all 3 trimesters. Only neural tube closure sits inside that 3 to 4 week folate-sensitive zone. Here's a D440 OA exam tip for you. When the question asks about the critical folate window, always look for day 21 to 28 or week 3 to 4. Quick recall hook, 21 to 28, the tube cannot wait.
10. A home health nurse is counselling a new mother who has just started breastfeeding her infant for the first time this week. Which daily fluid intake recommendation should the nurse share to support adequate milk production and maternal hydration during this period? A. 1 litre per day. B. 2 litres per day. C. 3 litres per day. D. 4 litres per day. Can you guess the answer? Correct answer, C. 3 litres per day. Explanation: option C is correct because breastfeeding mothers are advised to drink about 3 litres of fluid daily. This level supports steady milk production and replaces the extra fluid losses tied to lactation and maternal metabolism. Option A is incorrect because 1 litre per day falls well below the fluid needs of a lactating woman. This amount would leave her underhydrated and could reduce her milk supply over time. Option B is incorrect because 2 litres per day approaches typical adult baseline needs, but does not cover the additional fluid losses tied to active milk production during regular breastfeeding each day. Option D is incorrect because 4 litres per day exceeds the standard recommendation and could risk electrolyte dilution. The evidence-based target for lactation sits lower than this amount for most healthy mothers.
Let's work through fluid needs during breastfeeding. Milk production pulls water out of the mother's body at a steady rate. A breastfeeding mother produces somewhere around 750 milliliters of milk per day, and that water has to come from somewhere. Add that to baseline daily fluid needs, and the recommendation lands at about 3 liters per day total. 1 liter sits far below baseline adult needs, much less the added load of lactation. 2 liters covers typical daily needs for a non-lactating adult, but does not replace the extra water leaving the body through breast milk. 4 liters goes past the recommended amount and risks electrolyte dilution. 3 liters hits the evidence-based target for most healthy breastfeeding mothers and keeps both milk supply and maternal hydration where they need to be. Here's a D440 OA exam tip for you. When the question asks about daily fluids for lactation, the answer is 3 liters. Quick recall hook, 3 for 3. 3 letters in mom, 3 liters a day.
11. A nurse is teaching a newly diagnosed hypertensive client about the eating pattern most often recommended to bring blood pressure down without needing medication increases. Which diet pattern best matches this clinical goal based on current published nutrition guidelines? A. Paleo-style eating. B. Low-carbohydrate ketogenic plan. C. High-protein animal-based plan. D. Dietary approaches to stop hypertension. Can you guess the answer? Correct answer. D. Dietary approaches to stop hypertension. Explanation. Option D is correct because the DASH diet targets hypertension through low sodium, high potassium, and high fiber intake. It pushes fruits, vegetables, and low-fat dairy while pulling back on saturated fat and sweets. Option A is incorrect because paleo-style eating often includes high-sodium cured meats and lacks the dairy emphasis tied to the potassium and calcium pattern that supports blood pressure reduction. Option B is incorrect because the low-carbohydrate ketogenic plan is not the guideline-supported approach for hypertension. It also restricts many fruits and grains central to blood pressure management. Option C is incorrect because a high-protein, animal-based plan often adds saturated fat and sodium while limiting the plant-based potassium and fiber sources that directly help lower blood pressure.
Let's walk through why the DASH diet keeps winning the hypertension conversation. DASH stands for dietary approaches to stop hypertension. It was built specifically to lower blood pressure through food rather than medication. The pattern pushes fruits, vegetables, whole grains, and low-fat dairy while pulling back on sodium, saturated fat, and added sugar. High potassium from produce helps the kidneys drop excess sodium. High calcium and magnesium from dairy support healthy vascular tone. Low sodium reduces fluid retention. Paleo eating can run high in sodium through cured meats. Ketogenic plans restrict the fruits and grains that deliver the very potassium and fiber DASH relies on. High-protein animal-based plans often pile on saturated fat and sodium. None of those match the evidence base for lowering blood pressure the way DASH does. Here's a D440 OA exam tip for you. When the question mentions hypertension and diet, the answer is always DASH. Quick recall hook. Dash your blood pressure down. DASH.
12. A nurse is planning meals for a client with chronic kidney disease who has not yet started dialysis treatment. Which food grouping best matches the renal diet priorities of limiting potassium, phosphorus, sodium, and protein load on the kidneys? A. Bananas, oranges, and processed meats. B. Apples, rice, and limited lean protein. C. Spinach, nuts, and whole milk. D. Ham, cheese, and dried beans. Do you know the answer? Correct answer. B. Apples, rice, and limited lean protein. Explanation. Option B is correct because apples are low in potassium. Rice is low in phosphorus and potassium, and carefully portioned lean protein protects declining kidney function. This combination fits the standard pre-dialysis renal diet pattern. Option A is incorrect because bananas and oranges are high potassium fruits, and processed meats carry heavy sodium and phosphorus additives. This grouping directly conflicts with the renal diet restrictions needed. Option C is incorrect because spinach is high in potassium. Nuts are high in phosphorus and potassium, and whole milk raises phosphorus load. These choices overload the kidneys with restricted minerals across the board. Option D is incorrect because ham is high in sodium, cheese is high in phosphorus, and dried beans are high in both potassium and phosphorus. This grouping violates multiple renal diet restrictions at the same time.
Let's map out what a pre-dialysis renal diet looks like at the grocery store. Chronic kidney disease before dialysis means the kidneys still work partly, but cannot handle heavy loads of potassium, phosphorus, sodium, or protein. So the diet has to pull back on all four. Apples are low in potassium. Rice is low in both phosphorus and potassium. Lean protein in measured portions keeps the nitrogen waste load manageable. That combination fits the pre-dialysis pattern cleanly. Bananas and oranges pack high potassium. Processed meats stack sodium and phosphorus additives. Spinach and nuts carry high potassium and phosphorus. Whole milk adds more phosphorus on top. Main. Ham, cheese, and dried beans hit every restricted mineral at once. The apple, rice, and limited lean protein option is the only grouping that respects every renal restriction in one meal. Here's a D440 OA exam tip for you. When the question involves kidney disease before dialysis, scan for low potassium fruits, rice, and small protein portions. Quick recall hook: apple, rice, lean protein. Renal.
13. A nurse is discharging a client with newly diagnosed heart failure and reviewing the top dietary priorities for home self-management. Which two restrictions should the nurse emphasize above all others to prevent fluid retention and reduce symptom flares? A. Fluid and sodium restriction. B. Protein and calcium restriction. C. Iron and magnesium restriction. D. Potassium and vitamin D restriction. Can you guess the answer? Correct answer: A. Fluid and sodium restriction. Explanation: Option A is correct because heart failure clients need tight fluid and sodium limits. Excess sodium drives fluid retention, raises cardiac workload, and worsens pulmonary congestion, while fluid restriction prevents volume overload and shortness of breath. Option B is incorrect because protein and calcium are needed for tissue maintenance and bone health. Restricting them offers no benefit in heart failure and risks muscle wasting or bone loss over time. Option C is incorrect because iron and magnesium support oxygen transport and cardiac rhythm respectively. Restricting them could worsen anemia or cause arrhythmias in clients already dealing with heart failure symptoms. Option D is incorrect because potassium and vitamin D are often monitored but not broadly restricted in heart failure. Many heart failure clients actually need potassium replacement when taking loop diuretic therapy.
Here's the core dietary rule for heart failure self-management. The failing heart cannot pump efficiently, so any added fluid volume makes the work harder. Sodium holds water. Every extra gram of sodium pulls more fluid into circulation, which backs up into the lungs and peripheral tissue. That is why fluid and sodium restriction sits at the top of every heart failure teaching plan. The combination reduces pulmonary congestion, lower limb edema, and shortness of breath. Protein and calcium restriction would just cause muscle wasting and bone loss for no cardiovascular gain. Iron and magnesium restriction would worsen anemia and risk arrhythmias. Potassium and vitamin D restriction does not fit heart failure, and many heart failure clients actually need potassium replacement because of loop diuretic therapy. Fluid and sodium restriction is the one right answer. Here's a D440 OA exam tip for you. When the question asks about heart failure home diet priorities, pick fluid and sodium. Quick recall hook: 2 US words, salt and sips. Both down.
14. A nurse is reviewing the dietary plan for a client recovering from glomerulonephritis linked to an untreated strep infection last month. Which nutrient adjustments would best support kidney recovery and prevent further tissue breakdown during the acute phase of illness? A. High protein, low carb, and high sodium. B. High sodium, high fat, and low fiber. C. Low sodium, decreased protein, and increased carbs. D. Low calcium, high potassium, and high protein. Can you guess the answer? Correct answer: C. Low sodium, decreased protein, and increased carbs. Explanation: Option C is correct because glomerulonephritis management calls for fluid and sodium restriction, decreased protein to lower kidney workload, and increased carbohydrates to supply energy and prevent the breakdown of protein stores for fuel. Option A is incorrect because high protein strains inflamed glomeruli, and high sodium drives fluid retention along with blood pressure elevation. This combination worsens kidney stress during the acute illness period. Option B is incorrect because high sodium drives fluid retention and hypertension. High fat adds no recovery benefit, and low fibre is unrelated to glomerular recovery priorities in this diagnosis at all. Option D is incorrect because low calcium offers no benefit for glomerulonephritis. High potassium can build up in impaired kidneys, and high protein raises the nitrogen waste load on damaged glomeruli.
Let's unpack the glomerulonephritis diet in plain terms. The glomeruli are the filters inside the kidney. Post-strep glomerulonephritis causes inflammation that reduces filtering capacity temporarily. During recovery, 3 dietary shifts protect the inflamed tissue: low sodium to control fluid retention and blood pressure, decreased protein to cut nitrogen waste, and increased carbohydrates to supply energy without breaking down the body's own protein for fuel. The carbohydrate bump matters because when energy runs short, the body catabolizes muscle protein, which dumps more nitrogen into already stressed glomeruli. High protein, low carb, and high sodium would worsen every problem at once. Only the low sodium, low protein, high carb pattern matches the clinical goal. Here's a D440 OA exam tip for you. When the question involves kidney filter inflammation, remember 2 downs and 1 up. Sodium down, protein down, carbs up. Quick recall hook, down, down, up, like a cheat code for kidneys.
15. A nurse is reviewing a cardiac diet education handout with a client who has recently started on statin medication for elevated cholesterol levels. Which food category should the client most strongly limit to align with standard American Heart Association dietary guidance? A. Fresh fruits and vegetables. B. Trans fats and processed meats. C. Whole grain breads and oats. D. Legumes and low-fat dairy. Can you guess the answer? Correct answer, B. Trans fats and processed meats. Explanation. Option B is correct because Heart Association guidance flags trans fats and processed meats as major contributors to cardiovascular risk. Both raise LDL cholesterol and inflammation markers, speeding up plaque buildup inside the coronary arteries over time. Option A is incorrect because fresh fruits and vegetables form the backbone of heart-healthy eating. These foods deliver fibre, potassium, and antioxidants that support cardiovascular protection rather than worsen overall heart disease risk. Option C is incorrect because whole grain breads and oats provide soluble fibre that helps lower LDL cholesterol. Cardiac guidance pushes these foods forward rather than restricting them for heart health goals. Option D is incorrect because legumes and low-fat dairy supply protein, fibre, and calcium without the saturated fat load of red meat. Both foods fit well within American Heart Association dietary patterns.
Let's dig into what the American Heart Association actually pushes people to cut. Statin therapy works on cholesterol, but medication alone does not fix diet-driven cardiovascular risk. The association flags 2 categories as the worst offenders for heart disease: trans fats and processed meats. Trans fats raise LDL and drop HDL at the same time, a double hit on vascular health. Processed meats carry high sodium, nitrates, and saturated fat, all linked to coronary plaque and inflammation. Fresh fruits and vegetables supply fiber, potassium, and antioxidants, so they belong on the plate, not off it. Whole grain breads and oats supply soluble fiber that actually lowers LDL. Legumes and low-fat dairy deliver protein and calcium without the saturated fat load of red meat. So the one category to strongly limit is trans fats and processed meats. Here's a D440 OA exam tip for you. When the question mentions heart health or statin therapy, look for trans fats and processed meats on the cut list. Quick recall hook: trans and processed HE trouble. Triple TI.
16. A nurse is reviewing admission orders for a client with a complete small bowel obstruction who cannot take anything by mouth. Which form of nutritional support is most appropriate when the gastrointestinal tract cannot be used safely at all? A. Oral supplements between meals. B. Nasogastric tube feeding. C. Percutaneous endoscopic gastrostomy. D. total parenteral nutrition. What do you think is the answer? Correct answer, D, total parenteral nutrition. Explanation: option D is correct because total parenteral nutrition delivers liquid nutrients directly into the bloodstream through a central line placement. It is the correct choice when the gastrointestinal tract is not functional, accessible, or safe to use. Option A is incorrect because oral supplements require a working swallowing mechanism and a functional gastrointestinal tract to absorb nutrients. A complete bowel obstruction makes oral intake impossible and unsafe for the client. Option B is incorrect because nasogastric tube feeding delivers formula into the stomach and still requires a functional gut below the feeding point. A complete bowel obstruction blocks this pathway entirely for the client. Option C is incorrect because percutaneous endoscopic gastrostomy is a feeding tube placed into the stomach. Like nasogastric feeding, this route still depends on a functioning lower gastrointestinal tract to absorb nutrients.
Let's walk through the nutrition ladder for a client with a complete bowel obstruction. Nutrition support follows a simple rule: if the gut works, use the gut. Oral supplements need a working swallow and a functional gastrointestinal tract. Nasogastric feeding sends formula into the stomach, but still needs a functional gut below the tube. A percutaneous endoscopic gastrostomy, or PEG tube, sits in the stomach and also depends on the intestine downstream. All three enteral routes assume the gut below the feeding point can absorb nutrients. A complete small bowel obstruction blocks that path entirely. Nothing can get through. So the only safe way to deliver nutrition is total parenteral nutrition, which bypasses the gut completely and sends concentrated nutrients into the bloodstream through a central line. TPN is the correct answer when the gut is shut down. Here's a D440 OA exam tip for you. When the stem says non-functional gut or complete obstruction, the answer is TPN. Quick recall hook: TPN 2 through the vein. Gut is on the bench.
17. A nurse is preparing to discontinue total parenteral nutrition for a client who has resumed reliable oral intake this morning. Which action is most important to prevent hypoglycemia during this transition from intravenous nutrition back to regular food intake? A. Gradually decrease the flow rate. B. Stop the infusion immediately. C. Double the oral intake first. D. Clamp the central line abruptly. Do you know the answer? Correct answer, A. Gradually decrease the flow rate. Explanation: option A is correct because TPN delivers concentrated dextrose, so the body adapts insulin output to the steady supply. Tapering the flow rate over 1 to 2 hours prevents rebound hypoglycemia once the infusion stops. Option B is incorrect because stopping the infusion immediately leaves insulin levels elevated from the dextrose-driven adaptation. Blood sugar drops quickly, putting the client at real risk for rebound hypoglycemia. Option C is incorrect because doubling oral intake first does not reliably match the continuous dextrose delivery that TPN provides. The client may still experience a blood sugar drop when the drip actually stops. Option D is incorrect because clamping the central line abruptly causes the same physiological hit as stopping the infusion without warning. The sudden loss of dextrose triggers hypoglycemia in a primed pancreas.
Here is the physiology behind tapering TPN safely. Total parenteral nutrition runs a concentrated dextrose solution into the bloodstream around the clock. The pancreas adapts by pumping out steady insulin to match that constant sugar load. If the infusion stops suddenly, the dextrose vanishes, but the insulin is still circulating. Blood glucose crashes fast. That is called rebound hypoglycemia, and it can cause confusion, shakiness, seizures, or worse. The safe way to stop TPN is to gradually decrease the flow rate over 1 to 2 hours, which gives the pancreas time to dial back insulin output as the sugar supply tapers off. Stopping the infusion immediately, clamping the line abruptly, or simply doubling oral intake first all fail to match the physiology. A slow taper is the one action that prevents the hypoglycemia risk. Here's the D440 OA exam tip for you. When the question asks how to stop TPN, pick the gradual option every time. Quick recall hook: taper prevents the nosedive. TPN.
18. A nurse finishes inserting a nasogastric tube for feeding and has just aspirated a small amount of gastric contents into a syringe. Which action should the nurse complete next before starting the prescribed tube feeding through the new tube? A. Flush the tube with saline. B. Start feeding at low rate. C. Check the pH of aspirate. D. Remove the tube and restart. Do you know the answer? Correct answer. C. Check the pH of aspirate. Explanation. Option C is correct because checking the pH of the aspirated contents helps confirm gastric placement before tube feeding begins. An acidic pH reading supports stomach location, though X-ray remains the gold standard for final verification. Option A is incorrect because flushing the tube with saline before confirming placement could deliver fluid directly into the lungs if the tube is misplaced. Placement verification must come before any flushing step. Option B is incorrect because starting the feeding before verifying placement risks aspirating formula into the lungs, which can cause pneumonia, respiratory distress, and other serious pulmonary complications in the client. Option D is incorrect because removing the tube based on a successful aspiration wastes a possibly correct placement. The nurse should first verify placement through pH testing and imaging before pulling the tube.
Let's break down the step that keeps tube feeding safe. After inserting a nasogastric tube, the nurse must confirm the tip is in the stomach before putting anything through it. Aspirating a small amount of gastric contents is the first check, but the aspirate itself needs testing. Measuring the pH of that aspirate gives the next piece of evidence. Stomach contents are acidic, usually with a pH of 5 or lower, while lung secretions sit closer to neutral or slightly alkaline. An acidic reading supports gastric placement, but an X-ray remains the gold standard for final verification, but pH testing is the immediate bedside step. Flushing with saline before confirming placement could send fluid into the lungs. Starting the feeding skips verification entirely and risks aspiration. Removing a possibly correct tube wastes work. Checking the pH comes next. Here's a D440 OA exam tip for you. After aspiration, the next bedside step is always pH. Quick recall hook: aspirate then acid check. Then A.
19. A clinical dietitian is recommending enteral feeding rather than parenteral nutrition for a client whose gastrointestinal tract remains fully functional. Which benefit of enteral feeding most strongly supports this preference in hospitalized clients with intact gut function and working bowels? A. Faster weight gain outcomes. B. Preserves gut function and integrity. C. Requires no nursing supervision. D. Eliminates any risk of aspiration. Can you guess the answer? Correct answer, B. Preserves gut function and integrity. Explanation. Option B is correct because enteral feeding keeps nutrients flowing through the intestinal tract, which preserves the villi, supports gut immunity, and prevents atrophy of the gastrointestinal lining that occurs with parenteral-only nutrition over time. Option A is incorrect because enteral feeding does not necessarily produce faster weight gain than parenteral nutrition does. The core advantage lies in maintaining gut structure and immune function, not speed of weight recovery. Option C is incorrect because enteral feeding still requires close nursing supervision to monitor tolerance, tube placement, residual volumes, and potential complications at the bedside, It is not a hands-off method. Option D is incorrect because enteral feeding still carries aspiration risk, especially with gastric feeding or elevated residuals. The head of the bed must stay elevated to lower, but not remove this risk.
Let's talk about why enteral feeding beats parenteral nutrition when the gut still works. The intestinal lining is not just a passive pipe. It is a living barrier made up of villi, tight junctions, and immune cells that require contact with food to stay healthy. When no nutrients flow through the gut, the villi shrink, the barrier weakens, and gut immunity drops. Bacteria can then cross from the intestine into the bloodstream, a problem called translocation. Enteral feeding keeps food moving through the intestine, which preserves villi, maintains the barrier, and supports gut immunity. Faster weight gain is not a guaranteed advantage. Aspiration risk never drops to zero with gastric feeding either. The core reason clinicians prefer the gut when it works is structural and immune preservation. Here's a D440 OA exam tip for you. When the question asks why enteral beats parenteral, pick the option about gut structure or integrity. Quick recall hook. Feed the gut to save the gut.
20. A nurse is monitoring a client who has been receiving total parenteral nutrition through a central line for the past 2 weeks. Which complication tied directly to the central line itself should the nurse watch for most carefully? A. Constipation and bloating. B. Hair thinning and dry skin. C. Muscle cramps and weakness. D. Pneumothorax and air embolism. Can you guess the answer? Correct answer, D. Pneumothorax and air embolism. Explanation. Option D is correct, because central line placement and tubing changes carry specific risks of pneumothorax and air embolism. These mechanical complications tie directly to the central venous access route that TPN delivery absolutely requires in clinical practice. Option A is incorrect because constipation and bloating relate to gastrointestinal function rather than central line access problems. TPN bypasses the gut entirely, so these symptoms are not the top central line concern here. Option B is incorrect because hair thinning and dry skin might reflect micronutrient gaps over longer time periods, but are not tied to the central line placement itself. These signs develop slowly rather than acutely. Option C is incorrect because muscle cramps and weakness point to electrolyte shifts in the blood rather than central line hazards. Mechanical central line risks focus on the vascular and pleural complications listed above.
Let's focus on what can go wrong with the central line that delivers TPN. Total parenteral nutrition needs a central venous catheter because the solution is too concentrated for a peripheral vein. The line usually sits in the subclavian or internal jugular vein, right next to the pleura and major vessels. 2 mechanical complications tie directly to that placement. The first is pneumothorax, where the needle nicks the lung during insertion and air leaks into the pleural space, causing sudden chest pain and shortness of breath. The second is air embolism, where air enters the vein through a disconnected tubing hub or cracked line and travels to the heart or lungs, which can cause cardiac collapse. Constipation, hair thinning, and muscle cramps may show up for other reasons during TPN therapy, but they are not central line complications. Pneumothorax and air embolism are the mechanical risks to watch. Here's a D440 OA exam tip for you. When the question asks about central line complications specifically, go straight to pneumothorax and air embolism. Quick recall hook, central line to chest or clot. 2C problems.
21. A nurse is triaging patients on a medical floor and wants to flag those at highest risk for aspiration due to swallowing difficulty during meals. Which client profile most clearly matches the typical picture of dysphagia in acute care settings? A. Older adult with Parkinson's disease. B. Young adult with seasonal allergies. C. Middle-aged client with a sprained ankle. D. Teenager with mild acne concerns. What do you think is the answer? Correct answer, A. Older adult with Parkinson's disease. Explanation: option A is correct because dysphagia often appears with Parkinson's disease, Alzheimer's disease, stroke, head and neck cancer, and neuromuscular disorders. Older adults living with these conditions face the highest risk of aspiration and nutritional decline. Option B is incorrect because seasonal allergies cause nasal and respiratory symptoms rather than swallowing impairment. A young adult with allergies carries no elevated risk for dysphagia or aspiration based on this condition. Option C is incorrect because a sprained ankle is an orthopedic injury unrelated to cranial nerves, swallowing muscles, or cognitive function. This client faces no meaningful dysphagia risk from the listed condition. Option D is incorrect because mild acne in a teenager is a dermatological concern with no link to swallowing mechanics or nutrition. The teenager's swallowing function and nutritional status remain completely unaffected here.
Let's pin down who actually develops dysphagia in acute care. Dysphagia means trouble swallowing, and it usually shows up when the nerves or muscles that coordinate swallowing get damaged. Parkinson's disease tops that list because it slowly strips away motor control, including the coordinated movements of tongue, soft palate, and pharynx. Add in Alzheimer's disease, stroke, head and neck cancer, and neuromuscular disorders, and you have the classic dysphagia population. Older adults living with any of these conditions face the highest risk of aspiration and nutritional decline. Seasonal allergies hit the nose and sinuses but leave swallowing intact. A sprained ankle has nothing to do with cranial nerves. Mild acne is a skin concern. None of those three touch the swallowing reflex. The older adult with Parkinson's disease is the right answer because the disease directly attacks motor pathways that control the swallow. Here's a D440 OA exam tip for you. When the question asks about dysphagia risk, look for a neurological condition in an older adult. Quick recall hook, neuroillerakatin dysphagia denga.
22. A nurse is advancing the diet of a post-operative client whose bowel sounds have returned and who is tolerating early intake well without symptoms. What is the correct standard order of diet progression from most restricted toward a regular food tray? A. Regular mechanical soft, full liquid, clear. B. Mechanical soft, clear, pureed, full liquid. C. Clear liquid, full liquid, pureed, mechanical soft. D. Pureed, clear, full liquid, mechanical soft. Do you know the answer? Correct answer: C. Clear liquid, full liquid, pureed, mechanical soft. Explanation: option C is correct because diet progression moves from clear liquid to full liquid to pureed and then mechanical soft before reaching a regular tray. Each step slowly increases texture complexity as the client's tolerance clearly improves. Option A is incorrect because this order reverses the progression, starting at regular and moving backward to clear liquid tint. Post-operative advancement moves toward regular food, not away from it in clinical practice. Option B is incorrect because this sequence places mechanical soft before clear liquid, which skips the lowest residue starting point. Early post-operative diets begin with the simplest clear fluids first, not textured foods. Option D is incorrect because this order places pureed before clear liquid, which is too advanced for immediate post-operative intake. Clear liquid always anchors the starting point of standard diet progression in practice.
Let's map out postoperative diet progression step by step. After surgery, the gut needs time to wake up before it can handle solid food again. Bowel sounds return first, then small sips of fluid, then gradually thicker and more complex textures. The standard order starts with clear liquid, which leaves almost no residue and passes through quickly. Next comes full liquid, which includes milk, cream soups, and pudding. Then pureed, which is food blended smooth without chunks. Then mechanical soft, which is soft cooked food that needs minimal chewing. Regular tray comes last. The order reads clear, full, pureed, mechanical soft, regular. Any option that starts at regular and moves backward or skips clear liquid, breaks the progression logic. The correct sequence moves from simplest fluid to most complex solid. Here's a D440 OA exam tip for you. When the question asks about post-op diet order, always start at clear liquid. Quick recall hook, CFPMR. Clear, full, pureed, mechanical, regular.
23. A speech-language pathologist recommends thickened liquids for a client with moderate dysphagia after a recent stroke. Which rationale best explains why thickened liquids help protect this client in this specific clinical situation involving impaired airway protection? A. Thick liquids deliver more calories. B. Slower flow reduces aspiration risk. C. Thick liquids raise potassium levels. D. Thick fluids improve dental health. Do you know the answer? Correct answer. B. Slower flow reduces aspiration risk. Explanation. Option B is correct because thickened liquids move more slowly through the mouth and pharynx, giving the impaired swallowing reflex more time to direct fluid safely away from the airway and into the esophagus without aspirating. Option A is incorrect because thickening agents are added for texture control rather than calorie density. The primary reason thickened liquids are prescribed is airway protection during swallowing, not added nutritional value. Option C is incorrect because thickening agents do not specifically raise potassium in the fluid. Electrolyte levels depend on the underlying beverage rather than the thickener itself or the final consistency reached. Option D is incorrect because thickened liquids do not affect dental health in any meaningful clinical way. The rationale behind thickening focuses entirely on reducing aspiration risk during the swallowing process itself.
Here is why speech pathologists reach for thickened liquids in dysphagia care. After a stroke, the swallow reflex often becomes delayed or weak. Thin liquids like water or juice move fast through the mouth and pharynx. That speed outpaces an impaired reflex, so fluid can spill into the airway before the epiglottis closes to protect the lungs. Thickening the liquid slows the flow. Slower flow gives the delayed reflex enough time to trigger, direct the fluid down the esophagus, and protect the airway. That airway protection is the core rationale. Thickening agents do not add meaningful calories, do not raise potassium, and do nothing for dental health. The single reason clinicians prescribe thickened liquids is to reduce aspiration risk by slowing the fluid down so the swallow can catch up. Here's a what you do D440 OA exam tip for you. When the question asks why thickened liquids help, pick the option about slower flow or aspiration risk. Quick recall hook, thicker, slower, safer.
24. A nurse is planning meals for a client with painful inflammation of the oral mucosa after a recent round of chemotherapy treatment. Which combination of food choices would best support comfort, healing, and continued nutrient intake during this difficult period? A. Hot spicy soup and citrus juice. B. Crunchy toast and raw carrots. C. Salty chips and sour pickles. D. Room temperature smoothies and soft eggs. Do you know the answer? Correct answer. D. Room temperature smoothies and soft eggs. Explanation. Option D is correct because stomatitis calls for soft, moist, room temperature foods that avoid irritation of the oral lining. High protein, high calorie smoothies and soft cooked eggs deliver nourishment without aggravating the inflamed mucosa during recovery. Option A is incorrect because hot spicy soup burns inflamed tissue and citrus juice delivers acid that stings open ulcers directly. Both choices worsen pain and slow healing of the oral mucosa. Option B is incorrect because crunchy toast and raw carrots scrape inflamed tissue and can tear fragile mucosal surfaces during chewing. Hard textures sit among the top irritants to avoid in stomatitis care. Option C is incorrect because salty chips abrade sore tissue and sour pickles deliver acidic irritation to the lining. Both the texture and the acid content worsen pain and delay healing of the mucosa.
Let's work through food choices for stomatitis after chemo. The oral mucosa gets inflamed, raw, and often ulcerated after certain chemotherapy drugs. Anything that irritates the lining makes eating painful and slows healing. The safe foods share three features: soft texture, room temperature, and mild flavor. Room temperature smoothies and soft cooked eggs fit that pattern perfectly and still deliver protein and calories the client needs. Hot spicy soup burns tissue, and citrus juice stings open ulcers with acid. Crunchy toast and raw carrots scrape fragile surfaces and can tear the lining. Salty chips abrade sore tissue, and sour pickles hit with both acid and salt. For stomatitis, think cool, soft, and bland. That is the one option that supports comfort and keeps nutrient intake steady during recovery. Here's a D440 OA exam tip for you. When the question mentions stomatitis or mouth sores, pick the room temperature. Soft, bland option every time. Quick recall hook. 3 S's. Soft, smooth, soothing.
25. A nurse caring for a client newly diagnosed with dysphagia is coordinating the interdisciplinary care team for safe feeding at home. Which 3 specialists are most directly involved in assessing and managing the client's swallowing and nutritional needs from the outset? A. Dietitian, speech pathologist, occupational therapist. B. Pharmacist, chaplain, and social worker. C. Radiologist, phlebotomist, and lab technician. D. Surgeon, dermatologist, and optometrist. Can you guess the answer? Correct answer: A. Dietitian, speech pathologist, occupational therapist. Explanation: Option A is correct because registered dietitian nutritionists guide texture and calorie planning. Speech-language pathologists evaluate swallowing mechanics at the bedside, and occupational therapists address feeding posture and adaptive equipment for the client living with dysphagia. Option B is incorrect because pharmacists, chaplains, and social workers support broader care but do not directly assess or manage the mechanics of swallowing or the nutritional planning that dysphagia recovery requires. Option C is incorrect because radiologists, phlebotomists, and lab technicians support testing and imaging rather than direct bedside management of dysphagia. These roles do not drive swallowing therapy or actual diet selection. Option D is incorrect because surgeons, dermatologists, and optometrists handle operative, skin, and eye concerns respectively. None of these specialists primarily evaluate or manage dysphagia at the bedside with daily care.
Let's look at who actually shows up on the dysphagia care team. 3 specialists carry the bulk of the work. The registered dietitian nutritionist plans textures, calories, and protein targets that match the client's swallowing ability. The speech-language pathologist performs the swallowing evaluation, tests different consistencies, and designs the swallowing therapy at the bedside. The occupational therapist addresses feeding posture, adaptive utensils, and the physical mechanics of getting food from plate to mouth safely. Those 3 roles cover mechanics, nutrition, and the act of self-feeding. Pharmacists, chaplains, and social workers do important supportive work, but do not directly assess or manage swallowing. Radiologists, phlebotomists, and lab technicians support testing rather than bedside management. Surgeons, dermatologists, and optometrists handle completely different body systems. Dietitian, speech pathologist, and occupational therapist is the right answer. Here's a D440 OA exam tip for you. When the question asks about the dysphagia team, scan for dietitian, SLP, and OTA. Quick recall hook, DSO. Diet, swallow, occupation.
26. A dietitian is teaching a wellness class about the 3 main nutrient groups that supply energy to the body each day, which grouping correctly identifies the 3 macronutrients that deliver calories and serve as the foundation of daily dietary planning for healthy adults. A. vitamins, minerals and water. B. Fiber, water and table salt. C. Carbohydrates, proteins and fats. D. Sodium, potassium and calcium. Do you know the answer? Correct answer, C. Carbohydrates, proteins and fats. Explanation. Option C is correct because carbohydrates, proteins, and fats are the three macronutrients that supply energy for the body. Each plays a distinct role in daily metabolism, tissue maintenance, and fuel delivery across every life stage. Option A is incorrect because vitamins, minerals, and water are micronutrients and essential substances that support metabolism, but do not directly supply calories for energy the way macronutrients consistently do. Option B is incorrect because fiber is a type of carbohydrate. Water supplies no calories, and table salt is a sodium source rather than one of the three recognized energy-yielding macronutrients. Option D is incorrect because sodium, potassium and calcium are minerals and electrolytes involved in fluid balance and signaling. None of these substances deliver calories or function as a macronutrient fuel source.
Let's sort out macronutrients versus everything else. Macronutrients are the three nutrient groups that supply calories, carbohydrates, proteins, and fats. Each plays a distinct role in daily metabolism. Carbs fuel the brain and muscles. Proteins build and repair tissue. Fats provide concentrated energy and support hormone production and fat-soluble vitamin absorption. Vitamins, minerals, and water are essential for life, but do not supply calories directly. They are micronutrients and essential substances, not macronutrients. Fiber is technically a type of carbohydrate but passes through mostly unabsorbed. Water has 0 calories and table salt is just sodium. The three macronutrients that feed the body are carbohydrates, proteins, and fats. Here's a D440 OA exam tip for you. When the question asks which group supplies calories, pick the option with carbs, protein, and fat. Quick recall hook. CPF, the calorie-providing family.
27. A dietitian is explaining which macronutrient packs the highest energy per gram when teaching a weight management class this week. Which macronutrient delivers far more calories gram for gram than protein or carbohydrate and deserves careful portion attention at every meal? A. Protein from lean meat. B. Carbohydrate from whole grains. C. Dietary fiber from vegetables. D. Fat from oils and butter. Can you guess the answer? Correct answer, D. Fat from oils and butter. Explanation. Option D is correct because fat delivers the most calories per gram of any macronutrient, more than twice what protein or carbohydrate provides. This energy density makes portion control with fats central to weight management planning. Option A is incorrect because protein delivers fewer calories per gram than fat does. While protein supports tissue repair and satiety, it is not the most energy-dense macronutrient on the plate. Option B is incorrect because carbohydrate delivers fewer calories per gram than fat does. Carbs provide quick fuel for the brain and muscles, but they rank lower than fat in energy density. Option C is incorrect because dietary fiber passes through the digestive tract with very limited caloric absorption. Fiber adds bulk and supports regularity rather than serving as a dense source of calories.
Here is the calorie density ranking every student needs memorized. Carbohydrates and proteins each supply 4 calories per gram. Fat supplies 9 calories per gram, more than double. That makes fat the most energy-dense macronutrient by a wide margin. Oils and butter fall squarely into that high-density category, which is why small portions add up quickly on a calorie count. Alcohol sits at 7 calories per gram, but is not a standard macronutrient. Protein from lean meat hits the important 4-calorie mark but does not top fat. Carbohydrate from whole grains also delivers 4 per gram. Dietary fiber passes through the digestive tract, mostly unabsorbed, so it contributes almost nothing to daily calorie totals. When weight management comes up and the question asks about the most energy-dense macronutrient, fat is always the answer. Here's a Wagyu D440 OA exam tip for you. When you see energy density or calories per gram, jump to fat. Quick recall hook, fat 19. Rhymes, easy to tie.
28. A nurse is counselling a client, recovering from major burn injuries, about which macronutrient supports tissue repair most directly during the healing period. Which macronutrient becomes especially important during recovery, surgical healing and pregnancy, when amino acid demand climbs sharply in the body? A. Protein from eggs and fish. B. Simple sugar from candy. C. Saturated fat from butter. D. Trans fat from margarine. What do you think is the answer? Correct answer, A. Protein from eggs and fish. Explanation. Option A is correct, because protein supplies the amino acids that build and repair tissue, making it the priority macronutrient during burn recovery, wound healing, surgical recovery, and pregnancy when tissue synthesis demands rise sharply. Option B is incorrect because simple sugar from candy offers quick energy but no amino acids. It cannot rebuild damaged tissue or support the surge in protein synthesis that healing burns require during recovery. Option C is incorrect because saturated fat from butter supplies energy, but no amino acids for tissue repair. Excess saturated fat also raises cardiovascular risk without meeting the healing client's protein needs. Option D is incorrect because trans fat from older margarine formulations raises cardiovascular risk and offers no amino acids. This fat type works against healthy recovery rather than supporting burn-related tissue rebuilding.
Let's look at why protein takes the spotlight during burn recovery. Burns destroy skin, underlying tissue, and sometimes muscle. Rebuilding that tissue requires amino acids, and amino acids come from protein. Burn clients lose nitrogen rapidly through wound drainage and increased metabolism, so daily protein needs can double compared to healthy adults. Eggs and fish are high-quality protein sources that deliver all the essential amino acids for tissue synthesis. The same protein priority applies during wound healing, surgical recovery, and pregnancy when tissue demand climbs sharply. Simple sugar from candy provides quick energy but no amino acids. Saturated fat from butter is just calories. Trans fat from older margarines raises cardiovascular risk and still offers no amino acids. Only protein rebuilds tissue, and the burn client needs it more than any other macronutrient during recovery. Here is a Wagyu D440 OA exam tip for you. When the question mentions burns, wounds, surgery, or pregnancy tissue demand, pick protein. Quick recall hook, protein patch the tissue.
29. A dietitian is helping a vegan client identify plant-based foods that deliver all 9 essential amino acids in a single food source. Which of the following foods counts as a complete protein for someone avoiding every animal product in the daily diet? A. Plain white rice only. B. Soy products like tofu. C. Plain iceberg lettuce. D. Apple slices alone. Do you know the answer? Correct answer, B. Soy products like tofu. Explanation. Option B is correct, because soy products like tofu, tempeh and edamame are complete proteins because they contain all 9 essential amino acids. Soy stands out as one of the few plant foods carrying complete protein status on its own. Option A is incorrect because plain white rice is a grain that lacks sufficient amounts of the essential amino acid lysine. Rice must be paired with beans or legumes to form a complete protein profile. Option C is incorrect because plain iceberg lettuce contains very little protein overall and does not provide a meaningful amount of any essential amino acid. Lettuce works as a base vegetable, not a protein source. Option D is incorrect because apple slices alone contain negligible protein and lack essential amino acids in useful amounts. Apples provide fiber and carbohydrates rather than standing in as a complete protein food.
Let's break down complete versus incomplete plant proteins. Complete protein contains all 9 essential amino acids in useful amounts. Animal sources like eggs, fish, and meat are naturally complete. Most plant sources are incomplete, meaning they fall short in at least one essential amino acid. Soy is the major exception. Tofu, tempeh, and edamame all carry complete protein status on their own, which makes soy a cornerstone of vegan diets. Other complete plant proteins include quinoa and buckwheat, but soy is by far the most common. Plain white rice lacks enough lysine and must be paired with beans to complete the amino acid profile. Iceberg lettuce has almost no protein. Apples are fiber and carbohydrates with negligible protein content. When the question asks for a single plant food that counts as a complete protein, soy products like tofu are the right answer. Here's a D440 OA exam tip for you. When the stem says vegan plus complete protein, the answer is soy. Quick recall hook: soy stands solo.
30. A nurse is explaining the difference between complex and simple carbohydrates to a newly diagnosed pre-diabetic client during a teaching session. Which food pairing the best illustrates the complex carbohydrate category that supports slower blood sugar rise and steadier energy through the day? A. Table sugar and white bread. B. Candy bars and regular soda. C. Whole grains and fresh vegetables. D. Fruit juice and honey sticks. Can you guess the answer? Correct answer: C. Whole grains and fresh vegetables. Explanation: Option C is correct because whole grains and fresh vegetables supply complex carbohydrates with fiber and slower digestion. This pattern supports gradual blood sugar release, steadier energy levels, and better glycemic control for pre-diabetic clients. Option A is incorrect because table sugar and white bread are refined, simple carbohydrates. Both foods spike blood glucose quickly and offer little fiber, which works against the pre-diabetic client's glycemic control goals. Option B is incorrect because candy bars and regular soda deliver concentrated simple sugars with almost no fiber. These foods trigger rapid blood sugar spikes and belong in the category to avoid, not the target pattern. Option D is incorrect because fruit juice and honey sticks deliver rapidly absorbed simple sugars stripped of fiber. These simple carbs cause the same quick glucose spike that the client is trying to avoid daily.
Let's sort simple carbs from complex carbs at the grocery store. Simple carbohydrates are small sugar molecules that digest quickly. They spike blood glucose fast and drop it fast, which works against glycemic control. Complex carbohydrates are longer sugar chains packaged with fiber and other nutrients. They digest slowly, raise blood glucose gradually, and deliver steadier energy through the day. Whole grains like oats, brown rice, and whole wheat bread sit in this group, along with fresh vegetables that add fiber without the sugar punch. For a pre-diabetic client, the complex carb pattern supports better blood sugar control and lower diabetes risk. Whole grains and fresh vegetables is the pairing that fits complex carbohydrates cleanly. Here's a YouTube D440 OA exam tip for you. When the question mentions prediabetes or steady blood sugar, pick whole grains and vegetables. Quick recall hook: complex sukan blood sugar.
31. A nurse is counselling a client with iron deficiency anemia about pairing foods to boost iron uptake from plant sources during meals. Which food would best support iron absorption when eaten at the same meal as iron-rich spinach or a fortified breakfast cereal? A. Glass of cold whole milk. B. Mug of strong black coffee. C. Cup of hot green tea. D. Orange slices or bell pepper. What do you think is the answer? Correct answer: D. Orange slices or bell pepper. Explanation. Option D is correct because vitamin C, rich foods like oranges and bell peppers, boost iron absorption from plant-based sources. Pairing these foods with iron-rich meals raises the amount of iron the body actually pulls from the food. Option A is incorrect because calcium in milk competes with iron for absorption in the gut. Drinking milk with iron-rich meals lowers iron uptake rather than supporting it, which is the opposite of the goal. Option B is incorrect because tannins and polyphenols in coffee bind iron in the gut and block absorption. Coffee with meals can cut iron uptake significantly and should be separated from iron-rich foods. Option C is incorrect because tannins in green tea also bind iron and interfere with absorption. Tea with meals reduces the amount of iron the body can pull from plant sources rather than boosting uptake.
Let's look at how iron absorption actually works at the meal level. Iron from plant sources is called non-heme iron, and the body absorbs it poorly compared to the heme iron in meat. But vitamin C changes that equation. Vitamin C converts non-heme iron into a form the gut can pull in more efficiently, sometimes boosting absorption threefold. Orange slices and bell peppers are both packed with vitamin C, so pairing them with iron-rich spinach or fortified cereal maximizes iron uptake. Calcium in milk competes with iron for the same absorption pathway, so milk with iron foods cuts uptake rather than helping. Coffee and green tea contain tannins and polyphenols that bind iron in the gut and block absorption. All three of those drinks work against iron absorption. Vitamin C rich foods are the only option that actively boosts iron uptake. Here's a D440 OA exam tip for you. When the question asks what helps iron absorption, always pick vitamin C. Quick recall hook. C for citrus, C for carry iron in.
32. A home health nurse is teaching an older adult client about the vitamin primarily synthesized in the skin through direct sunlight exposure and also found in fortified milk and fatty fish. Which vitamin is the nurse describing in this teaching conversation? A. Vitamin D, B. Vitamin C, C. Vitamin K, D. Biotin. What do you think is the answer? Correct answer, A. Vitamin D. Explanation. Option A is correct because vitamin D is synthesized in the skin through sunlight exposure and is also found in fortified milk, egg yolks, and fatty fish. It works closely with calcium to support bone mineralization throughout life. Option B is incorrect because vitamin C is not synthesized through sunlight exposure. Humans obtain vitamin C from citrus fruits, berries, and vegetables rather than from skin production in response to sun. Option C is incorrect because vitamin K comes from dark leafy green vegetables and gut bacteria production. It is not made in the skin and does not follow the same sunlight-driven synthesis as vitamin D does. Option D is incorrect because biotin is a B vitamin obtained from eggs, nuts, and whole grains. It is not produced by skin exposure to sunlight and does not follow the vitamin D synthesis pathway at all.
Let's pin down the sunshine vitamin. Vitamin D is unique among vitamins because the body can make it when sunlight hits the skin. Ultraviolet B rays convert a cholesterol-based precursor in the skin into active vitamin D over a span of about 15 to 30 minutes of sun exposure. Food sources fill in the gap. Fortified milk, egg yolks, and fatty fish like salmon and mackerel carry useful amounts. Older adults often run low on vitamin D because skin synthesis drops with age, sun exposure tends to be limited, and dietary intake may not be enough. Vitamin C comes from fruits and vegetables, not skin synthesis. Vitamin K comes from leafy greens and gut bacteria. Biotin comes from eggs and nuts. Only vitamin D is made in the skin through sunlight, so the nurse's description points straight to vitamin D. Here's a D440 OA exam tip for you. When the question mentions skin synthesis or sunlight exposure, the vitamin is always D. Quick recall hook, D for daylight.
33. A community nurse is assessing an older man who presents with swollen, bleeding gums. slow wound healing, easy bruising, and a long history of alcohol misuse and poor diet. Which vitamin deficiency best matches this collection of clinical findings in an adult client? A. Vitamin K deficiency. B. Vitamin D deficiency. C. Vitamin C deficiency. D. Vitamin A deficiency. What do you think is the answer? Correct answer, C. Vitamin C deficiency. Explanation: option C is correct because scurvy from vitamin C deficiency shows up as swollen bleeding gums, slow wound healing, easy bruising, and loose teeth. Risk rises with alcohol misuse, smoking, and diets low in fresh fruits and vegetables. Option A is incorrect because vitamin K deficiency causes bleeding problems but does not typically produce the swollen gums and poor wound healing picture tied to classic scurvy in adults or adults with poor nutrition. Option B is incorrect because vitamin D deficiency shows up as bone pain, muscle weakness, and softer bones rather than bleeding gums and slow wound healing. The findings point more clearly toward a vitamin C deficit. Option D is incorrect because vitamin A deficiency shows up as night blindness, dry eyes, and skin changes. It does not produce the bleeding gums and delayed wound healing that vitamin C deficiency causes.
Here's how classic scurvy shows up at the clinic. Vitamin C supports collagen synthesis, and collagen holds connective tissue together, including blood vessels, gums, and skin. When vitamin C runs low for months, collagen production falters and the tissues that depend on it start to fail. Swollen bleeding gums, slow wound healing, easy bruising, and loose teeth are the classic signs of scurvy. Alcohol misuse and a diet without fresh fruits and vegetables together push the risk up sharply. Vitamin K deficiency causes bleeding, but not the gum swelling and slow wound healing picture. Vitamin D deficiency shows up as bone pain, muscle weakness, and softer bones, not bleeding gums. Vitamin A deficiency causes night blindness and dry eyes. The bleeding gums, slow wound healing, and bruising combination points straight to vitamin C deficiency. Here's a WEDU D440 OA exam tip for you. When the question lists bleeding gums and poor wound healing, think vitamin C, quick recall hook. C for collagen, C for cuts that heal.
34. A nurse is teaching a client newly prescribed warfarin about foods that interact with the medication by affecting blood clotting. Which food group should the client monitor closely for consistent daily intake to avoid unpredictable swings in clotting time during therapy? A. Red meats and pork. B. Dark leafy green vegetables. C. White potatoes and rice. D. Citrus fruits and berries. Can you guess the answer? Correct answer, B. Dark leafy green vegetables. Explanation: option B is correct because dark leafy greens like kale, spinach and collards are high in vitamin K, which directly affects clotting. Clients on warfarin need steady intake rather than large swings that disrupt medication dosing. Option A is incorrect because red meats and pork carry iron and protein but are not significant sources of vitamin K. These foods do not drive the clotting interactions that warfarin therapy specifically requires watching for. Option C is incorrect because white potatoes and rice are starchy carbohydrates with minimal vitamin K content. They do not affect warfarin action or clotting time in a clinically meaningful way during therapy. Option D is incorrect because citrus fruits and berries supply vitamin C and antioxidants but contain little vitamin K. These foods do not alter warfarin action or produce the clotting swings the nurse is teaching about.
Let's work through the warfarin-food interaction teaching point. Warfarin blocks vitamin K, which the liver needs to make clotting factors. The goal is to keep blood thin enough to prevent clots, but not so thin that bleeding becomes dangerous. Dosing depends on a steady balance between drug and vitamin K intake. That is why dark leafy green vegetables, matters so much on warfarin. Kale, spinach, collards, and broccoli all carry high vitamin Ki. The rule is not to avoid these foods entirely, but to keep intake consistent day to day. A big spinach salad one day, and none the next swings clotting time out of range. Red meats and pork are not major vitamin K sources. White potatoes and rice have minimal vitamin K. Citrus fruits and berries supply vitamin C, not K. Only dark leafy greens need careful monitoring for consistent daily intake. Here's a WEDU D440 OA exam tip for you. When the question mentions warfarin, always look for dark leafy greens and consistency. Quick recall hook: keep K constant.
35. A provider is reviewing a bone health plan for a postmenopausal woman at elevated risk for osteoporosis and recent bone density decline. Which vitamin and mineral pairing should the provider recommend to support calcium absorption and stronger bones over the coming years? A. Vitamin A and iron. B. Vitamin C and copper. C. Vitamin E and zinc. D. Vitamin D and magnesium. Do you know the answer? Correct answer: D. Vitamin D and magnesium. Explanation: option D is correct because vitamin D drives calcium absorption from the gut, and magnesium activates vitamin D and supports bone structure. This pairing gives postmenopausal women the strongest supporting cast for calcium uptake and bone mineralization. Option A is incorrect because vitamin A in excess can actually weaken bone and raise fracture risk. Iron supports oxygen transport but does not partner with calcium for bone building in the way vitamin D and magnesium do. Option B is incorrect because vitamin C supports collagen formation and copper supports connective tissue, but neither directly drives calcium absorption. This pairing does not anchor the bone health plan that calcium requires. Option C is incorrect because vitamin E and zinc serve antioxidant and immune roles. Neither nutrient drives calcium absorption or bone mineralization the way vitamin D and magnesium partner to strengthen bones.
Let's look at the bone health partnership for postmenopausal women. Calcium alone cannot build bone. It needs partners to get absorbed and laid down properly. Vitamin D drives calcium absorption in the gut. And without enough vitamin D, the calcium a person eats just passes through. Magnesium plays two roles. It activates vitamin D into its functional form, and it contributes directly to bone structure. Together, vitamin D and magnesium form the strongest supporting cast for calcium uptake and mineralization in postmenopausal women. Vitamin A in excess can actually weaken bone and raise fracture risk. Vitamin C supports collagen but does not drive calcium absorption. Vitamin A and zinc serve antioxidant and immune functions. None of those pairings match the calcium partnership that vitamin D and magnesium provide. Here's a WEDU D440 OA exam tip for you. When the question mentions calcium absorption or postmenopausal bone health, pick vitamin D and magnesium. Quick recall hook: D and MGK bone duo.
36. A newly diagnosed celiac client is reviewing a grocery list with a dietitian for the first time after positive antibody testing. Which category of foods must the client strictly avoid to prevent an immune reaction, intestinal damage, and chronic nutrient malabsorption over time? A. Wheat, barley, rye, and oats. B. Apples, pears, and bananas. C. Chicken, fish, and eggs. D. Potatoes, carrots, and squash. What do you think is the answer? Correct answer: A. Wheat, barley, rye, and oats. Explanation: option A is correct because celiac disease triggers an immune attack on the small intestine when gluten is eaten. Gluten lives in wheat, barley, rye, and oats, and lifelong avoidance of these grains is the treatment. Option B is incorrect because apples, pears, and bananas are naturally gluten-free fruits that pose no risk to the celiac client. These foods actually belong in the safe list rather than the avoid list during meal planning. Option C is incorrect because chicken, fish, and eggs are naturally gluten-free animal proteins. These foods form the protein foundation of a safe celiac diet, rather than the restricted list the client must avoid. Option D is incorrect because potatoes, carrots, and squash are naturally gluten-free vegetables. These starchy and root vegetables are fully safe for a celiac client and help replace restricted grain-based foods.
Let's work through the celiac avoid list at the grocery store. Celiac disease is an autoimmune condition where gluten triggers the immune system to attack the small intestine. The damage flattens the villi, blocks nutrient absorption, and causes symptoms ranging from diarrhea to anemia to growth failure in children. Gluten is a protein found in 4 grains: wheat, barley, rye, and oats. Oats themselves do not contain gluten, but are usually cross-contaminated with wheat during processing, so plain oats still land on the avoid list unless certified gluten-free. Apples, pears, and bananas are naturally gluten-free fruits. Chicken, fish, and eggs are gluten-free animal proteins. Potatoes, carrots, and squash are gluten-free vegetables. The only answer that lists gluten-containing grains is wheat, barley, rye, and oats. Here's a D440 OA exam tip for you. When the question mentions celiac or gluten avoidance, scan for wheat, barley, rye, oats. Quick recall hook: WBRO. Wheat, barley, rye, oats.
37. A nurse is discharging a client after an acute cholecystitis flare who's being managed conservatively without surgery for now. Which dietary pattern should the nurse recommend to reduce gallbladder strain and lower the chance of another painful attack at home? A. High fat with low fibre meals. B. Heavy cream sauces and deep fried foods. C. Low fat with small frequent meals. D. Large portions of red meat daily. What do you think is the answer? Correct answer: C. Low fat with small frequent meals. Explanation: Option C is correct because cholecystitis improves with low fat eating and smaller frequent meals. This pattern reduces gallbladder contraction and bile demand, lowering the chance of a painful attack while inflammation settles down. Option A is incorrect because high fat eating forces the gallbladder to contract hard, which worsens pain during inflammation. Low fibre is also unrelated to the goal of reducing gallbladder irritation after a flare. Option B is incorrect because heavy cream sauces and deep fried foods sit among the worst triggers for a cholecystitis client. These choices drive fatty meals that sharply increase the risk of another painful attack. Option D is incorrect because large portions of red meat bring heavy saturated fat loads that stress the inflamed gallbladder. This pattern triggers bile release and pain rather than supporting recovery at home.
Here is how to feed a gallbladder without setting it off again. The gallbladder releases bile to break down dietary fat. When inflammation hits, every fatty meal forces the irritated gallbladder to contract hard, which drives pain. The way to keep things calm is to pull back on fat intake and spread food across the day, in small portions, rather than hitting the gallbladder with one big load. Low-fat eating with small frequent meals lowers bile demand and reduces contractions. Meals should focus on lean protein, fruits, vegetables, and whole grains. High-fat with low-fiber meals push bile demand higher. Heavy cream sauces and deep-fried foods sit among the worst triggers. Large portions of red meat deliver heavy saturated fat that stresses the inflamed gallbladder. Only low fat with small frequent meals matches the recovery goal. Here's a D440 OA exam tip for you. When the question mentions gallbladder or cholecystitis, pick low fat and small frequent. Quick recall hook: low fat little plates.
38. A nurse is educating a client 3 weeks after Roux-en-Y gastric bypass surgery about episodes of nausea, cramping, sweating, and diarrhea within minutes after eating. Which dietary strategy best prevents this reaction during the post-bariatric recovery period at home? A. Drink sugary juices with meals. B. Avoid high sugar foods and sip fluids between meals. C. Eat one large meal each day. D. Add concentrated sweets as dessert. What do you think is the answer? Correct answer: B. Avoid high sugar foods and sip fluids between meals. Explanation: Option B is correct because dumping syndrome follows rapid gastric emptying of concentrated sugar into the small bowel. Avoiding high sugar foods, eating small frequent meals, and keeping fluids between rather than during meals best prevents symptoms. Option A is incorrect because sugary juices with meals directly trigger dumping syndrome by flooding the small bowel with concentrated sugar. This choice is exactly the opposite of what post-bariatric clients need to avoid. Option C is incorrect because eating one large meal daily stretches the surgical stomach pouch and overwhelms gastric capacity. Post-bariatric clients tolerate several small meals far better than a single large meal. Option D is incorrect because concentrated sweets as dessert trigger the same rapid sugar delivery that causes dumping. Avoiding concentrated sugars entirely gives the client the best control over symptoms after surgery.
Let's work through dumping syndrome after gastric bypass. Roux bypass shrinks the stomach pouch and reroutes food past part of the small intestine. When concentrated sugar hits that smaller pouch, it empties too quickly into the small bowel. The sudden sugar load pulls fluid into the gut and triggers a rush of insulin, causing nausea, cramping, sweating, diarrhea, and dizziness within 15 to 30 minutes of eating. This is dumping syndrome. The way to prevent it is simple in principle. Avoid high sugar foods, eat several small meals, and sip fluids between meals rather than with them. Sugary juices with meals trigger dumping directly. One large meal daily overwhelms the pouch. Concentrated sweets as dessert deliver exactly the sugar load that causes the reaction. Avoiding high sugar and separating fluids from meals is the right combination. Here's a Wagyu D440 OA exam tip for you. When the question mentions bariatric surgery and dumping, pick low sugar with fluids between meals. Quick recall hook: no sugar, sip between.
39. A nurse is counselling a client with a long history of diverticulitis. Flares about food choices that support colon health between flare episodes. Which dietary pattern best supports prevention during quiet periods when the bowel is not actively inflamed and symptoms have resolved? A. Low fibre diet with white bread. B. High sodium with processed meats. C. Raw nuts and seeds with every meal. D. High fibre with fruits and vegetables. Do you know the answer? Correct answer: D. High fibre with fruits and vegetables. Explanation: Option D is correct because between flares, a high fibre diet with fruits, vegetables, legumes, and whole grains supports colon health and prevents new outpouchings from forming. Fibre adds bulk and regularity, easing pressure on the colon wall. Option A is incorrect because a low fibre diet with white bread is reserved for acute flares when the bowel needs rest. Between flares, low fibre eating actually raises the risk of new outpouchings forming. Option B is incorrect because high sodium processed meats offer no protective value for diverticulitis and often come with low fibre content. This pattern does nothing to support colon health during quiet periods between flares. Option C is incorrect because raw nuts and seeds with every meal are traditionally limited after acute flares and can aggravate inflammation in susceptible clients. Fibre from softer plant sources is the safer prevention strategy.
Let's look at diverticulitis management between flares. Diverticula are small pouches that form in weak spots of the colon wall, often from years of low fibre eating and constipation. When those pouches become inflamed, the condition is called diverticulitis. During acute flares, the bowel needs rest, so a low fibre diet applies for a short period. But between flares, the goal shifts completely. High fibre from fruits, vegetables, legumes, and whole grains adds bulk to stool, prevents constipation, and reduces pressure on the colon wall. That lower pressure prevents new diverticula from forming. Low fiber eating between flares raises the risk of new outpouchings. High sodium processed meats offer no protective value. Raw nuts and seeds with every meal can aggravate susceptible clients. High fiber with fruits and vegetables is the correct prevention pattern during quiet periods. Here's a D440 exam tip for you. When the question asks about diverticulitis prevention between flares, pick high fiber. Quick recall hook: between flares, bring fiber.
40. A nurse is caring for a client receiving radiation therapy to the head and neck, who now reports painful mouth sores that make eating very difficult. Which teaching point best supports comfort, nutrient intake, and mucosal healing during this radiation-induced stomatitis episode at home? A. Choose soft foods at room temperature. B. Drink piping hot coffee with each meal. C. Add hot sauce to every dish daily. D. Chew dry pretzels between meals. Can you guess the answer? Correct answer. A. Choose soft foods at room temperature. Explanation. Option A is correct because stomatitis care centres on soft, moist, room temperature foods that avoid irritating inflamed oral tissue. High calorie and high protein soft foods support intake without scraping or burning the sore mucosa during meals. Option B is incorrect because piping hot coffee burns already inflamed oral tissue and worsens pain. Heat and caffeine both irritate sore mucosa and make it harder for the client to maintain adequate nutrient intake. Option C is incorrect because hot sauce and spicy foods aggravate open sores and drive severe pain during eating. Spicy foods top the list of irritants to avoid during any stomatitis episode, whatever the cause. Option D is incorrect because dry pretzels scrape and tear fragile mucosal surfaces. Hard and dry textures are among the worst choices for a client with stomatitis and directly work against healing the damaged lining.
Let's look at feeding a client with radiation-induced stomatitis. Radiation to the head and neck damages the rapidly dividing cells of the oral mucosa, leaving the mouth raw, sore, and often ulcerated. Eating becomes painful, and clients often lose weight just when they need calories and protein most. Comfort foods share three features: soft, moist, and room temperature. A lukewarm scrambled egg, a smoothie, mashed potatoes, or a room temperature nutrition shake can glide over sore tissue without adding pain. Piping hot coffee burns inflamed mucosa, and the caffeine adds irritation. Hot sauce, or any spicy food, drives severe pain by directly stimulating pain receptors in open sores. Dry pretzels scrape fragile surfaces and can tear the healing lining. Soft foods at room temperature is the one choice that supports comfort, nutrient intake, and mucosal healing at the same time. Here's a D440 OA exam tip for you. When the question mentions radiation, chemo, or mouth sores, pick soft and room temperature. Quick recall hook: cool, soft, smooth beats hot and spicy.
41. A nurse is teaching a newly diagnosed type 2 diabetic client about daily food choices that support steady blood sugar control across meals. Which eating pattern should the nurse recommend as the foundation of daily meal planning for this client at home? A. High glycemic sugary snacks. B. White bread and sweet cereal. C. Complex carbs, lean protein, healthy fats. D. Large portions of candy and soda. What do you think is the answer? Correct answer: C. Complex carbs, lean protein, healthy fats. Explanation. Option C is correct because diabetic meal planning builds on complex carbohydrates, lean proteins, and healthy fats for steady blood sugar control. This pattern slows glucose absorption, supports satiety, and protects against the swings tied to refined sugar. Option A is incorrect because high glycemic sugary snacks drive rapid blood sugar spikes followed by crashes. This pattern works against glycemic control and belongs in the category of foods diabetic clients are taught to limit. Option B is incorrect because white bread and sweet cereal are refined carbohydrates that raise blood glucose quickly. These foods lack the fibre and nutrient density needed to support steady diabetic blood sugar control. Option D is incorrect because large portions of candy and soda flood the bloodstream with rapidly absorbed sugar. This pattern sits at the far end of what a diabetic meal plan is designed to prevent.
Let's walk through the diabetic meal pattern that actually works day to day. Type 2 diabetes means the body either does not make enough insulin or does not respond to it well. The result is blood sugar that rises too high after meals and drops unpredictably between them. The meal pattern that keeps blood sugar steady has three parts: complex carbohydrates, lean protein, and healthy fats. Complex carbs, like whole grains, beans, and vegetables, digest slowly and raise blood glucose gradually. Lean protein from fish, poultry, and legumes supports satiety without adding saturated fat. Healthy fats from nuts, seeds, avocado, and olive oil slow digestion further and help absorb fat-soluble vitamins. High glycemic sugary snacks drive spikes and crashes. White bread and sweet cereal deliver refined carbs with little fiber. Candy and soda flood the bloodstream with pure sugar. Only the complex carb, lean protein, healthy fat pattern supports steady control. Here's a D440 OA exam tip for you. When the question asks about a diabetic meal plan, pick the option with complex carbs, lean protein, and healthy fats. Quick recall hook: CPF for steady sugar.
42. A nurse is checking on a diabetic client who reports sudden sweating, shakiness, and confusion about 30 minutes after taking a regular insulin dose before lunch. Which food choice best treats this low blood sugar episode quickly and safely in the outpatient clinic setting? A. Large plate of lean steak. B. Small glass of regular fruit juice. C. Handful of roasted almonds. D. Bowl of leafy green salad. What do you think is the answer? Correct answer: B. Small glass of regular fruit juice. Explanation. Option B is correct because hypoglycemia calls for rapidly absorbed simple carbohydrates like fruit juice, glucose tablets, or regular soda. A small portion raises blood sugar within minutes, then a longer-acting snack prevents a second drop. Option A is incorrect because a large plate of lean steak supplies protein and fat that digests slowly. This choice cannot raise blood sugar fast enough to reverse the acute hypoglycemia episode the client is experiencing. Option C is incorrect because roasted almonds offer protein, healthy fat, and fibre, but digest too slowly for acute treatment. Almonds work well between meals but cannot correct a rapidly dropping blood sugar. Option D is incorrect because a leafy green salad delivers fibre and vitamins with almost no usable sugar. This food cannot raise blood glucose quickly and does not treat acute hypoglycemia in any meaningful way.
Let's work through treating hypoglycemia at the bedside. When a diabetic client takes insulin and then eats too little or delays the meal, blood sugar drops fast. The classic signs show up within minutes: sweating, shakiness, confusion, pounding heart, and hunger. Left untreated, severe hypoglycemia can cause seizures or loss of consciousness. The treatment is the 15-15 rule. Give 15 grams of fast-acting simple carbohydrate, wait 15 minutes, then recheck blood sugar. A small glass of regular fruit juice, 4 glucose tablets, or half a cup of regular soda each deliver about 15 grams of quickly absorbed sugar. A large plate of lean steak digests too slowly. Roasted almonds are protein and fat, also too slow. A leafy green salad has almost no usable sugar. Only regular fruit juice delivers the fast, simple carbs the situation demands. Here's a D440 OA exam tip for you. When the question describes sudden sweating, shakiness, and confusion in a diabetic, reach for fast, simple sugar. Quick recall hook: juice for jitters.
43. A nurse is planning nutritional teaching for a client newly diagnosed with untreated hyperthyroidism, presenting with unintentional weight loss and constant hunger. Which dietary adjustment best supports this client's raised metabolic demands and prevents further loss of lean body mass during treatment? A. Low calorie with low protein. B. High fibre with raw vegetables. C. High iodine with seafood-heavy meals. D. High calorie with high protein. What do you think is the answer? Correct answer, D. High calorie with high protein. Explanation. Option D is correct because untreated hyperthyroidism ramps up metabolism and drives weight loss. A high-calorie, high-protein diet with adequate carbohydrates supports energy demands, preserves lean body mass, and prevents further weight loss during treatment. Option A is incorrect because low-calorie and low-protein eating worsens weight loss and lean mass loss in a hypermetabolic state. This pattern pushes the client deeper into catabolism rather than supporting recovery. Option B is incorrect because high fibre with mostly raw vegetables adds bulk without enough calories or protein to match the metabolic burn. Clients often also need low fibre options if hyperthyroidism causes diarrhea. Option C is incorrect because high iodine intake can worsen hyperthyroidism by giving the overactive thyroid more raw material to produce hormone. Iodine-rich diets are often limited rather than pushed in hyperthyroid care.
Let's look at feeding a hyperthyroid client. The thyroid gland controls metabolic rate. When it runs overactive, the body burns through calories at a much faster pace, which explains the unintentional weight loss and constant hunger. Muscle mass often breaks down too if intake cannot keep up with demand. The dietary fix is straightforward: raise calories and raise protein. High-calorie intake replaces the energy the overactive thyroid keeps burning. High protein supplies amino acids that protect lean muscle from catabolism. Adequate carbs spare protein from being used for fuel. Low-calorie and low-protein eating would accelerate weight and muscle loss, making the client worse. High fiber with raw vegetables adds bulk, but not enough fuel. High iodine actually worsens hyperthyroidism by giving the overactive gland more raw material for hormone production. High calorie with high protein is the one pattern that matches the clinical need. Here's a WebU D440 OA exam tip for you. When the question mentions hyperthyroidism or high metabolism, pick high calorie and high protein. Quick recall hook: high burn, high fuel.
44. A nurse is building a home care plan for a client managing type 2 diabetes through medication, diet, and lifestyle changes during daily life. Which combination of factors most fully supports steady glycemic management across the client's weekly routine at home? A. Medication, healthy eating. Activity, monitoring. B. Sleeping late and skipping morning meals. C. Eating one large meal each evening. D. Avoiding all physical activity daily. What do you think is the answer? Correct answer: A. Medication, healthy eating, activity, monitoring. Explanation. Option A is correct because glycemic management rests on 4 pillars working together: pharmacology like insulin or oral medications, healthy eating patterns, regular physical activity, and routine glucose monitoring. Missing any one pillar weakens overall blood sugar control. Option B is incorrect because skipping morning meals and sleeping late disrupt blood sugar patterns and raise hypoglycemia risk in medicated diabetic clients. This schedule works against the steady routine glycemic control requires. Option C is incorrect because eating one large meal each evening concentrates carbohydrate load into a single spike. This pattern produces dramatic blood sugar swings rather than the steady control the client is aiming for. Option D is incorrect because avoiding physical activity removes one of the strongest tools for improving insulin sensitivity. regular activity helps muscle cells pull glucose from the blood and directly supports glycemic control.
Here is how diabetes management actually works across a whole week of daily life. No single action controls type 2 diabetes well on its own. 4 pillars work together: medication, healthy eating, physical activity, and blood glucose monitoring. Medication covers what the pancreas and insulin receptors cannot. Healthy eating keeps glucose loads manageable at every meal. Physical activity improves insulin sensitivity so muscle cells pull glucose from the blood more efficiently. Monitoring gives the client and the care team data to adjust the plan. Drop any one pillar and control slips. Sleeping late and skipping morning meals disrupts blood sugar patterns and raises hypoglycemia risk if medication is already on board. Eating one large evening meal concentrates carbs into a spike. Avoiding physical activity removes one of the most powerful tools for improving glucose uptake. The 4-pillar answer is the only one that fits. Here's a D440 OA exam tip for you. When the question asks about overall diabetes control, scan for all 4 actions in one option. Quick recall hook, MEAM. Meds, eat, activity, monitor.
45. A nurse is counseling a client with recurrent urinary tract infections who also manages type 2 diabetes about helpful dietary choices and beverage options. Which drink recommendation best supports urinary health without disrupting the client's blood sugar control at the same time? A. Regular sugary cranberry cocktail. B. Heavily sweetened iced tea daily. C. Sugar-free cranberry juice. D. Strong coffee with each meal. Can you guess the answer? Correct answer, C. Sugar-free cranberry juice. Explanation. Option C is correct because sugar-free cranberry juice supports urinary health through natural compounds that limit bacterial attachment to the bladder wall without adding the concentrated sugar load that would raise blood glucose in a diabetic client. Option A is incorrect because regular sugary cranberry cocktail contains heavy added sugar that spikes blood glucose in diabetic clients. The added sugar outweighs the urinary health benefit the client would otherwise receive. Option B is incorrect because heavily sweetened iced tea adds concentrated sugar and caffeine, which can irritate the bladder. This drink works against both blood sugar control and urinary comfort for the client. Option D is incorrect because strong coffee with each meal contains caffeine that irritates the bladder and can worsen urinary symptoms. Coffee is listed among foods to limit for clients prone to urinary tract infections.
Let's work through a drink choice for a diabetic with recurrent UTIS. Cranberry compounds called proanthocyanidins prevent bacteria from sticking to the bladder wall, which makes cranberry juice a staple of UTI prevention teaching. The problem is that regular cranberry cocktail is loaded with added sugar, which spikes blood glucose in a diabetic client. Sugar-free cranberry juice keeps the urinary health benefit while removing the sugar load, which makes it the safest fit for both conditions at once. Regular sugary cranberry cocktail delivers concentrated sugar that outweighs the urinary benefit for a diabetic. Heavily sweetened iced tea stacks sugar and caffeine, a double strike against both blood sugar and bladder comfort. Strong coffee with every meal adds caffeine that irritates the bladder. Sugar-free cranberry juice is the one option that supports urinary health without disrupting glycemic control. Here's a D440 OA exam tip for you. When the question combines diabetes and UTI, pick sugar-free cranberry. Quick recall hook, cranberry without the candy.
46. A public health nurse is teaching a community class about lifestyle choices that support cancer prevention based on current American Cancer Society guidance. Which combination of actions best reflects the Society's most modifiable risk factors for preventing cancer across a lifetime of healthy living? A. Daily tanning beds and smoking. B. Heavy alcohol with every meal. C. High sugar diet and sedentary lifestyle. D. Plant-based diet and physical activity. Can you guess the answer? Correct answer. D. Plant-based diet and physical activity. Explanation. Option D is correct because the American Cancer Society points to dietary choices and physical activity as the most modifiable risk factors for cancer prevention. A plant-based eating pattern with regular physical activity anchors the Society's core guidance. Option A is incorrect because daily tanning beds and smoking are well-documented cancer-causing exposures, not prevention strategies. These behaviours sit squarely among the top actions the Society tells people to avoid entirely. Option B is incorrect because heavy alcohol with every meal raises cancer risk for several cancer types. The Society recommends limiting alcohol to 1 drink daily for women and 2 for men, not heavy daily intake. Option C is incorrect because high sugar eating and a sedentary lifestyle both raise cancer risk through obesity and inflammation. This combination represents the risk factors to change, not the prevention strategies to follow.
Let's look at what the American Cancer Society actually tells people to do. The Society focuses on modifiable risk factors, meaning the things a person can actually change. 2 big ones lead the list: what you eat and how much you move. A plant-based diet rich in fruits, vegetables, whole grains, and legumes lowers cancer risk through fiber, antioxidants, and reduced red and processed meat intake. Regular physical activity, meaning at least 150 minutes of moderate exercise per week, reduces risk for colon, breast, endometrial, and other cancers through weight control and anti-inflammatory effects. Daily tanning beds and smoking cause cancer rather than prevent it. Heavy alcohol with every meal raises risk for several cancers. High sugar and sedentary living pushes obesity and inflammation, 2 cancer accelerators. Plant-based diet and physical activity is the one option that actually matches the prevention guidance. Here's a Wagyu D440 OA exam tip for you. When the question mentions ACS cancer prevention, pick the plant diet plus exercise option. Quick recall hook: plants and pulse. Eat plants, raise your pulse.
47. A nurse is caring for an older adult with a stage 3 pressure ulcer who needs targeted nutritional support for tissue repair and skin healing. Which dietary priority best supports wound healing in this clinical situation during the extended recovery period at home? A. High protein and vitamin C, rich foods. B. Low calorie and low protein intake. C. High sodium and processed snack foods. D. Low vitamin with restricted fluid intake. What do you think is the answer? Correct answer: A. High protein and vitamin C rich foods. Explanation. Option A is correct because pressure ulcer healing demands extra protein for tissue rebuilding and vitamin C for collagen formation. Adequate calories, fluids, and zinc also support healing, but protein and vitamin C carry the strongest healing role. Option B is incorrect because low calorie and low protein intake starve the healing process. Without enough amino acids and energy, the body cannot rebuild damaged tissue, and the pressure ulcer often worsens rather than closing. Option C is incorrect because high sodium processed snacks offer empty calories without the amino acids, vitamins, and minerals needed for wound repair. This pattern works against healing rather than supporting tissue rebuilding. Option D is incorrect because restricting vitamins and fluids blocks the collagen formation and circulation needed for healing. Dehydration and vitamin deficits both slow wound closure in older adults with pressure ulcers.
Let's walk through what a stage 3 pressure ulcer actually needs from food. Pressure ulcers at stage 3 reach through the skin into subcutaneous tissue. Closing that wound requires the body to build new tissue from scratch. 2 nutrients carry the strongest healing roles. Protein supplies the amino acids that fibroblasts turn into new collagen and new tissue. Vitamin C is required for collagen cross-linking, the step that makes new tissue strong enough to hold. Without enough vitamin C, collagen stays weak and wounds fall apart. Add adequate calories, fluids, and zinc, and the healing environment is complete. Low calorie and low protein intake starves the healing process. High sodium processed snacks offer empty calories without amino acids or vitamins. Restricting vitamins and fluids blocks collagen formation and circulation. High protein with vitamin C rich foods is the only combination that drives wound closure. Here's a D440 OA exam tip for you. When the question mentions pressure, ulcer, or wound healing, pick high protein and vitamin C. Quick recall hook. PNC patch skin closed.
48. A dietitian is counseling a client who has followed a strict vegan diet for 10 years and now reports fatigue, numbness, and tingling in the feet, and a sore red tongue. Which nutrient deficiency most commonly explains this set of findings in a long-term vegan client? A. Vitamin C deficiency. B. Sodium deficiency. C. Vitamin B12 deficiency. D. Chloride deficiency. Can you guess the answer? Correct answer, C. Vitamin B12 deficiency. Explanation. Option C is correct because vitamin B12 is found almost exclusively in animal products, so long-term vegans face real risk of deficiency. Classic signs include fatigue, peripheral neuropathy with tingling, sore tongue, and megaloblastic anemia over time. Option A is incorrect because vitamin C deficiency presents as bleeding gums, slow wound healing, and easy bruising. Vegans typically get plenty of vitamin C from fruits and vegetables, so this deficit is uncommon in this group. Option B is incorrect because sodium deficiency is rare in most diets, and usually tied to excessive losses rather than low intake. Vegan eating patterns generally supply adequate sodium through processed plant foods and added salt. Option D is incorrect because chloride deficiency is very uncommon in typical diets, including vegan ones. Chloride usually comes along with sodium from table salt, so isolated deficiency is not a realistic concern here.
Let's work through the long-term vegan deficiency picture. Vitamin B12 is made by bacteria and is found almost exclusively in animal products, meat, fish, eggs, and dairy. A vegan diet that excludes every animal source runs slowly toward B12 deficiency over years, because the liver stores a substantial supply that can last 3 to 5 years before symptoms appear. Once stores run out, the classic signs show up together: fatigue from megaloblastic anemia, numbness and tingling in the feet from peripheral neuropathy, a sore red tongue called glossitis, and sometimes memory problems or mood changes. A 10-year vegan with those exact findings points straight at B12. Vitamin C deficiency causes bleeding gums and poor wound healing, not neuropathy. Sodium deficiency is rare and comes from excessive losses, not vegan eating. Chloride deficiency is almost unheard of in any typical diet. Only B12 matches the clinical picture. Here's a D440 OA exam tip for you. When the question describes a long-term vegan with tingling feet, sore tongue, and fatigue, the answer is B12. Quick recall hook: B12, beef, milk, eggs. No animals, no B12.
49. A nurse is teaching a pregnant client about food safety practices to prevent listeria, salmonella, and other foodborne illnesses during pregnancy at home. Which combination of practices best reduces the client's foodborne illness risk during meal preparation and food storage throughout her pregnancy? A. Raw eggs and unpasteurized milk. B. Undercooked poultry and rare meat. C. Soft unpasteurized cheeses daily. D. Proper cooking and cold storage. Do you know the answer? Correct answer, D. Proper cooking and cold storage. Explanation. Option D is correct because food safety during pregnancy rests on proper cooking of meats, poultry, eggs and fish to safe internal temperatures along with prompt refrigeration and good hand hygiene. These practices reduce listeria, salmonella and other illness risks Option A is incorrect because raw eggs and unpasteurized milk are classic sources of salmonella and listeria infection. Pregnant clients are specifically told to avoid these foods because of the risks to mother and developing fetus. Option B is incorrect because undercooked poultry and rare meat raise salmonella, campylobacter, and toxoplasmosis risks. These foods sit on the avoid list during pregnancy rather than representing safe food handling practices. Option C is incorrect because soft, unpasteurized cheeses like brie and queso fresco carry listeria risk, which is especially dangerous during pregnancy. These cheeses should be avoided rather than consumed daily during pregnancy.
Let's work through food safety during pregnancy. Pregnancy changes immune function enough to raise the risk of foodborne illness dramatically. Listeria infection can cross the placenta and cause miscarriage, stillbirth, or severe newborn illness. Salmonella and toxoplasmosis also pose real risks to mother and fetus. Two core practices cut that risk sharply: proper cooking and cold storage. Proper cooking means heating meat, poultry, eggs, and fish to safe internal temperatures that kill pathogens. Cold storage means refrigerating leftovers within 2 hours, keeping the refrigerator at 40 degrees Fahrenheit or below, and not leaving perishable food at room temperature. Raw eggs and unpasteurized milk carry salmonella and listeria directly. Undercooked poultry and rare meat bring salmonella, campylobacter, and toxoplasmosis. Soft, unpasteurized cheeses carry high listeria risk. Proper cooking and cold storage is the safe practice pair the client needs. Here's a D440 OA exam tip for you. When the question asks about preventing foodborne illness in pregnancy, pick the option with cooking and cold storage. Quick recall hook: heat it or cool it.
50. A nurse is teaching a chemotherapy client with a very low white blood cell count about foods to avoid during this immunocompromised period at home. Which dietary rule best protects the neutropenic client from foodborne infection during treatment and recovery between chemotherapy cycles? A. Avoid raw and undercooked foods. B. Eat raw sushi with each meal. C. Drink untreated well water daily. D. Share utensils with family members. What do you think is the answer? Correct answer: A. Avoid raw and undercooked foods. Explanation: Option A is correct because neutropenic clients face high infection risk and are taught to avoid raw and undercooked foods, unpasteurized products, unwashed produce, and shared utensils. Thoroughly cooked foods and strict food hygiene protect against foodborne infection. Option B is incorrect because raw sushi carries parasites and bacteria that a healthy immune system usually handles, but a neutropenic client cannot. Raw fish belongs at the top of the avoid list during chemotherapy. Option C is incorrect because untreated well water can carry bacteria, parasites, and other pathogens. Neutropenic clients need treated, filtered, or bottled water rather than untreated sources during their immunocompromised period. Option D is incorrect because sharing utensils spreads bacteria and viruses from mouth to mouth. Neutropenic clients need dedicated utensils, separate food handling, and careful hand hygiene to lower infection exposure at home.
Let's finish with food safety for a neutropenic client. Chemotherapy drops the white blood cell count, sometimes to levels where even mild infections turn serious. Neutropenic precautions extend to food because the normal immune defense that handles everyday bacteria is no longer there. The rule is simple: avoid raw and undercooked foods. Meat, poultry, fish, and eggs must be thoroughly cooked to safe internal temperatures. Unpasteurized milk, cheese, and juice are off the list. Raw sushi and rare steaks are especially risky. Produce needs thorough washing, and some clinicians recommend cooked fruits and vegetables during severe neutropenia. Shared utensils spread bacteria and viruses from person to person. Untreated well water can carry bacteria and parasites. Raw sushi sits at the top of the avoid list. Sharing utensils with family increases exposure. Avoiding raw and undercooked foods is the core neutropenic food rule. Here's a Bugyu D440 OA exam tip for you. When the question mentions chemotherapy, low WBC, or neutropenia, pick the option that avoids raw foods. Quick recall hook: cook it, kill it. Heat kills the bugs.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.